Hello, everyone, and thank you for tuning in. I am Mary Moko. I'm a member of the Provider Outreach and Education team at WPS Health Solutions, and assisting me today is my friend and colleague, Karen Curtis. Karen is going to be monitoring the chat feature and will be adding some links and other helpful information for you. Today, we're talking about Part B, Mental Health, the WPS policy and billing and coding article. This is the third in a string of sessions that I am providing, and I'm doing so to provide an entry-level introduction into Part B, outpatient mental health services. If you want to catch up on the past sessions, there has been two. You can find them on our YouTube channel. And if they're not already there, they'll be there soon on our Encore Presentations webpage. They do remain on our webpage, that Encore Presentations webpage, for a limited time, about 60 to 90 days. So why did I choose this topic for a series of webinars? I created this education based on survey responses from the provider community. We review those surveys that we ask you to complete after each and every event, and we take those responses very seriously as ways to improve our customers' knowledge and their overall satisfaction with their MAC, which is WPS. I invite you to visit our training center area of our website. We post the event materials for all webinars a few days in advance. So if you want to download a copy of the slide deck, you can find it easily on the live events webpage. There's also areas where you can find out about and register for upcoming educational events there on that live events webpage. The recording of this and other live webinars will be on our website as an encore presentation for anyone who missed the event, or if you simply want to go back and listen to it all over again, or to listen to certain parts of it because you can't skip around in that video recording. Now, depending on the number of events, we normally make those encore presentations available for about 60 to 90 days. You can also find them on our YouTube channel, where they remain until there is a decision to move them or that the information becomes no longer current. So use the chat feature today to add any questions that you have related to today's topic. And because we're doing seven different sessions, I've allotted 60 minutes for each of those sessions. So today I'm going to ask to keep those questions, and we do want your questions if you have them, to those topics that we are talking about today during this 60-minute webinar, and that is the policy and billing and coding article. I did send an email out to all of you yesterday explaining where you can find information that you're seeking. Some of you asked that you had, or mentioned that you had questions on other topics, and they will be those topics I previously covered in the first two sessions, perhaps those sessions in the future. So again, look to the live events webpage if you're interested in registering for them. And then there were a couple of other questions. They were really off topic, but I did want to help, so I put some resources into that email for you. But do use the live or the chat feature today. Karen is going to be monitoring that chat feature, and she'll ask me questions. I'm going to answer as many questions I can in the time allotted today, but if I can't get to your question, or if I need to do a little research on it, I will get those questions and answers off to you in an email following today's event. We include this disclaimer in our education, and we do so for a number of reasons. We want to let you know that we made every effort to make certain the information that we're providing today is accurate and complete to the best of our knowledge, but that information is indeed subject to change. You can find current coverage, regulations, and rulings out on the CMS website, and those and the information in the Code of Federal Regulations will always prevail. CMS prohibits recording of this event for profit-making purposes. And because we are recording this presentation and we plan to make it available as an encore presentation and YouTube video at no cost, we ask that you refrain from making recordings of any kind during today's presentation. Here is the description for the presentation I will provide today. This is the third session in a string of 7 sessions. I've included this snipping from the registration page that you used when you registered for today's event. The description states that during this live webinar, I'm going to be discussing why medical necessity is important. Specifically, I'm going to talk about local coverage determination, or LCD, L34616. It's titled Psychiatry and Psychology Services. That is the local policy that we use to provide coverage and indications for mental health services for Jurisdiction 5 and Jurisdiction 8 providers. That's Iowa, Kansas, Nebraska, Missouri, Indiana, and Michigan. And today's event is focusing on Part B, or those providers that submit claims on a CMS 1500 claim form or the 837P equivalent. I do want to point out that we did advertise this session as an entry-level introduction. So it is an overview of a lot of services, or those services rather, that Part B providers would consider submitting to Medicare for mental health services. I'm also going to talk about the billing and coding article, or sometimes we call this the companion article. It's the billing and coding article that goes along with, or is a companion to, that local coverage determination policy L34616. And the title of the billing and coding article is Billing and Coding, Psychiatry and Psychology Services. I'm sharing the American Medical Association CPT copyright notice with you. Your continued participation in this webinar infers that you agree to this copyright notice. Today, the information that I'm going to provide pertains to various types of Medicare providers, and within the policy itself, we will often use the word physician. When we talk about physician in this particular policy that I'll be covering today, we really do mean all of these types of providers. They're all governed by that policy. You can see that I have included the providers that I'll be talking about today. Specifically, I'll also be talking about some ancillary staff that renders or helps out in the psychiatry and psychology offices, rendering those services. So MDs, CNM is certified nurse midwife. You'll see clinical psychologist, clinical social worker, CPs and CSWs, doctor of osteopathy, another type of medical doctor, a DO. Independently practicing psychologists, or IPPs, and then we have our newest of mental health providers that can enroll and submit claims to Medicare. That is the marriage and family therapist, the MFT, and the mental health counselor, MHC. And finally, nurse practitioners and physician assistants as well. You can see the NP and PA designations there for those providers. Section 1862A1A of the Social Security Act states that no Medicare payment can be made under Medicare Part A or Part B for items or services that are not medically necessary. And the exact verbiage from the Social Security Act is here on this slide, and I'm not going to read it to you now. The language is a little bit different and not like we normally speak, but the bottom line is that Medicare can't pay for any service, any Part A or Part B service or item, when it is not medically necessary. And this really is what some of us refer to as the overarching criteria for coverage. So how do MACs determine if an item or service is medically necessary? There are 3 things that they consider. If is the item or service needed for the diagnosis or treatment of a medical condition? Is it provided for diagnosis, direct care, and treatment of a medical condition? And really, does it meet those standards of good medical practice in that local area? And is the service not mainly for the convenience of the patient or the provider? MACs would expect the answer to all of these questions to be yes. Well, medical necessity is the number one consideration for Medicare payment. I talked about that overarching or all-encompassing rule for Medicare payment, or requirement, I should say, for Medicare payment. There is often some other requirements other than medical necessity that Medicare has to consider in order to make payment. And when I answer those questions that providers pose to me, I always try to remember to throw in this phrase, otherwise covered by Medicare. Because of course, sometimes I'm talking about specifically medical necessity, but we need to remember that besides medical necessity, there are other requirements for payment. So I like to throw in that verse or that phrase, it must be otherwise covered by Medicare. And I've included on this slide for you some examples of what we mean by that. It can't be a duplicate service. The services have to be covered. They have to be covered by law. In other words, what we're talking about here is that they need to meet any statutory requirements. The services can only be covered when they're correctly submitted. They must be submitted by an eligible provider, and then, of course, the beneficiary needs to be eligible as well. And these are just some of the examples. There, of course, are more. So when we talk about coverage and for Medicare, the overarching criteria or the number one consideration is it medically necessary? Because the Social Security Act requires that it is. And then it needs to be otherwise covered by Medicare. Local coverage determinations, or LCDs, are a type of Medicare policy. These are defined by the Social Security Act. And you can see here on this slide, I have the link to the section of the Social Security Act that speaks to LCDs. These are a determination by a MAC that explains um, how that MAC will look at medical necessity, or what it is that the MAC is going to require in order to meet medical necessity. Um, Policies do describe coverage on a national basis also, and those are those national coverage determinations. But a local coverage determination is a decision made by a MAC on whether an item or service is reasonable and necessary, and therefore covered by Medicare within that specific MAC's jurisdiction. So a local policy written by one MAC applies only to that MAC, not to other MACs. And local policies, like national policies, define medical necessity. In the absence of a national coverage determination, why would a MAC choose to develop an LCD? Well, the reasons are here on this slide. There are often new technologies that come about, and the MAC may write a local policy in order to define the appropriate use of those new technologies. Perhaps certain services represent a program vulnerability in that there is an abuse history or potential. Another reason for writing an LCD. However, the most common reason for publishing an LCD is the last one listed here, because the service is a high volume or high dollar service. I like to tell people when I talk about policies that policies equal edits. When there's an active policy, there are most often automated edits that assure that that claim meets payment criteria and processes correctly. Now, some of the edits, due to what is written in the policy, will require what we call complex review. And complex review are just more words to explain that documentation needs to be reviewed. That's what complex review is the review of the actual documentation, as opposed to an automated edit where no documentation needs to be looked at. The documentation needs to be there for each and every service the provider bills, but when making a determination for coverage, the MAC wouldn't need to review that documentation for those automated edits. So one example of a service that requires a complex review is when a not otherwise classified code is submitted to Medicare. Of course, we would need documentation then to determine coverage and payment. You can search for LCDs, billing and coding articles, and policy articles by number, by code or the title, or you can even use a keyword. We have a code lookup tool available on our website's homepage. There is a link provided. You can also search NCDs using that same tool, and I'm going to show you what it looks like. I'm going to pull a screen over here so you can take a look at it. And this just happens to be the home page of the WPS website. Right here is that tool that I was talking about. Over on the left side, it says Code Lookup Tool. By clicking into these radio buttons, you can choose to search LCD in an article or look up LCD in articles by codes, titles, or definitions. So for example, today I'm talking about L34616. That's the policy ID. I happen to know it. So if I wanted to find it or a link to it, I could just simply key that here into it, L34616. You know, maybe I want to look for a particular CPT code. I can do that, or HCPCS code. And I can even use a title or a keyword rather. When you're using a keyword, however, such as psychiatry, that keyword lookup is only going to bring back a result if that keyword appears in the title. Okay, so something to remember. With this code lookup tool on our website, you can also look up NCDs the same way. Okay, so that's the lookup tool. Very, very handy. Sometimes new CPT codes come about and you want to know, does this CPT code appear in a local coverage determination or an article? Okay, so if you're using the tool again for to search for keywords, remember that it only brings back a match if it appears in the title. Now, once approved, MAC LCDs are housed in the National Searchable Medicare Coverage Database, and I've included a link for that as well. So today I am focusing on LCD L34616. The title is Psychiatry and Psychology Services, and consistent with the required formatting for LCDs, this policy identifies the contractor, it provides LCD and general information, it includes a revision history and links to associated documents such as that companion article, that coding and billing article that I talked about earlier. There's a section for keywords in local coverage determinations, but it's been my experience that this is seldom used. Now, because this LCD that we're talking about today, and I've linked to it here on this slide, is published or was published by WPS, it applies only to jurisdictions 5 and 8. Now, if you haven't looked at the policy recently, you might not know that this policy was revised on October 31st of 2024. The revision history explains what changed. And I do want to show you what I'm talking about here. So I had the article pulled up already, and I'm going to pull it over so you can see it. See this notice? Superseded. That means that there is a version that is newer than this particular one that I'm looking at. If you use this link, it will take you to it. And I actually pulled up, I believe, the latest version. No, I didn't. Right now they don't automatically take you to the newest version, so you need to use this link. But I'm going to go ahead and choose that link because I told you that this was recently updated. The effective date is 10/31. I think I told you it was updated on 10/31, but it was actually updated on 10/21. The effective date is 10/31. The status is that is currently in effect, and right here this blue button is what you would use to view it. Okay, so this is the policy. I am going to scroll down rather quickly, so look away if that makes you a little bit dizzy. Here is a link to that billing and coding article. It's near the end of the policy. And then, of course, within each local coverage determination, there is the revision history. Okay, and that is right here. So each change, we are required, all MACs are required to take a look at a local coverage determination, or review it, I should say, at least every 2 years. Sometimes there's minor typographical changes that are being made, and that's really what happened on 10/31, that particular update. This explains why the policy was updated. Okay. They also added some marriage and family therapist and mental health counselor service information to the policy. So that's a quick way of keeping track of what changes. And all of these sections of a policy, it doesn't matter if we write it or Noridian writes it or Palmetto writes it. We all write our own local coverage determinations, but every single one of them includes all of this information you see here on this slide. Contractor information, LCD information, that really important revision history. All right, in the LCD information section of the LCD, WPS provides the Social Security Act and Code of Federal Regulations and CMS Internet-only manual citations. And what I'm talking about there is those responses to where does it say? Okay, we get those questions a lot. I want to show you that real quick here before I get started on all the policy information. It's right here at the beginning of the policy. 42 CFR. CFR stands for Code of Federal Regulations. The Social Security Act is what we use to, write this policy. There's also other references. Where does it say what clinical psychologists can bill for? Here it is, right here. So these are citations or where you can find the information that we use to publish the all-important coverage guidance in our local coverage determination. Right. As we're going over the policy, remember that you can suggest other topics for education when you complete that brief survey following the conclusion of this presentation today. Something I say may trigger a thought of yours, such as, gosh, I wish they would do a webinar on XYZ. Remember that and provide that feedback in that brief survey later on. It is in the coverage guidance section of the LCD where the coverage indications, limitations, and or medical necessity guidelines appear. And during this portion of the presentation, I'm actually going to what I call walk through the LCD to provide those coverage indication limitations and or medical necessity. Now, the first entry in this section of the policy is a definition of psychiatry and psychology services. Next, the policy states that references to provider throughout this particular policy includes physicians and non-physicians who are acting within their state scope of practice. In other words, the state in which they're practicing in has certified or licensed them to render the service that they're rendering to the Medicare beneficiary. So that's at the beginning of the policy. And I touched upon the fact earlier that when we say physician in this policy, we're talking about those physicians and non-physician practitioner providers that are able to render the services. Okay, so something to keep in mind here is that description of psychiatry and psychology services. Trying to highlight here. Just some good information for you about information we've included in that policy. All right, next up, let's start that walk through the policy. And this is what you're going to see first under the general coding section or the article guidance section of the policy. So this section addresses psychiatry services with evaluation and management, or E&M services, I'll call them. This slide explains that some psychiatry services may be reported with evaluation and management or even other services, and sometimes an E&M code is used to report only an E&M service, but an E&M code may also be reported with a psychotherapy add-on code. It's important to recognize that the E&M service is based on the physician's work, and it includes those medically necessary services done to evaluate and treat the patient. So it really is a separate service than the psychotherapy service. Okay, so the psychotherapy would then be an add-on code when it's rendered on the same day during the same session for the same patient. The first specific service that is addressed in our policy is the psychiatric diagnostic evaluation. The policy includes a description of this service, and it provides a cross-reference to information about provision of this service as it relates to nervous system stimulators for chronic intractable pain. The policy states that rules for this service apply for both the psychiatric diagnostic evaluation with and without a medical service, because there are separate codes that describe these. So I want to pull the policy back over here and show you as I'm walking through here what I'm talking about. And that the first service-specific guideline in our policy is the psychiatric diagnostic interview exam, 90791 and 90792. All right, let's go back to the PowerPoint here. Within the policy or the coding and billing articles, we state the same provider can't report an E&M code on the same day as this. We state this service can't be billed with a psychotherapy service code on the same day. We also state that this service, the psychiatric diagnostic eval, can only be reported once per day, and that it may be reported more than once for a patient with or when separate evaluations are conducted with the patient and their informants. In certain circumstances, others can be seen or may be seen in lieu of the patient. All of this is written right in the policy. This slide and the next one are those that address the most common reason that we receive questions about this service, this psychiatric diagnostic evaluation, both with and without a medical service. Now, based on our policy, WPS considers this service medically necessary once every 6 months per episode of illness. So if you bill it more often, documentation will be required to support medical necessity. But when that second claim comes in, it's going to deny for frequency, and we will have to check for the medical reason why more than one service was rendered for the same patient within 6 months per episode of illness. Now, the last bullet on this slide indicates that the LCD reference article, that's that billing and coding article, you can link to it at the end of the policy. It's titled Billing and Coding, Psychiatry and Psychology Services, provides the guidelines for frequency. So it delves into the guidelines for those frequency edits that we apply during claim processing for this service, both with and without medical necessity. And here are those guidelines for frequency. The same provider can repeat this service if an extended break in treatment occurs. The article goes on to say 6 months from the last time the patient was seen or treated for their psychiatric condition. So that's what we're talking about here, is an extended break in treatment. We will consider payment more than once when the patient requires admission to an inpatient status for a psychiatric illness, and when there's a significant change in mental status requiring further assessment. That should say status, not states. So it is those edits that I talked about earlier, those edits that are programmed to make certain we're paying for only those items or services that are medically reasonable and necessary, that will cause a claim or this service to deny if it's billed more than once every 6 months. Now, I just got a question the other day, or perhaps it was a question that was submitted when you registered for this event, asking, can the MD do this service with a medical E&M? And then 4 days later, the social worker do the service without an E&M? Well, Medicare would have to ask you, why was it medically necessary to repeat that same service? You know, granted, one had the medical evaluation and management with it, and one was without the evaluation and management service, but it's otherwise the same service. So the reason why the second claim coming in would fail or deny is because it was more than once in a 6-month period for the same patient. So that's something that you need to consider or recognize, that yes, it's going to deny if another provider also bills it within that same 6 months. Why was it medically necessary for the second service to be rendered? Okay, so things to think about. If you look at the policy, explains why we're only paying once. Now, it also tells you that there are some of those situations where we may pay it a second time, and those were on a couple of the previous slides that I talked about. Okay. The billing and coding article also addresses billing this service for a patient with a neurological disorder or dementia. Specifically, we state that the same provider may repeat this service again for these reasons here on this slide. So there are situations where we may repeat the service. Now, if the service initially denies, your remittance advice is going to include your appeal rights. And what you would need to do then is request an appeal, that first level of appeal, which is the redetermination, the only appeal level done by WPS or by a MAC. And you would have to show us your documentation and reasons why, or reasons to support medical necessity for that second service for that patient. The LCD article also states that some provider types will substitute an E&M code for the psychiatric diagnostic evaluation service when required elements of the reported E&M are fulfilled. And that's going to, largely depend on the provider type that's billing. While some provider types are, based on their state scope of practice, able to render an evaluation and management service, some provider types can't. It's not part of their state scope of practice. E&M codes do not include psychotherapy. So when billing psychotherapy or rendering both psychotherapy and an evaluation and management service on the same day, you would need to report the psychotherapy with the psychotherapy add-on code. Next, in the local policy, WPS provides coverage information for interactive complexity, and this refers to those situations when there are communication or communicative difficulties during the psychiatric services. The policy article, A57480, that's the ID number for that policy article or that companion article that I talked about, lists those 4 communication difficulties. So reporting this code really represents increased work intensity that the psychotherapy service required due to that patient's communicative difficulty. It doesn't change the time for the service, but it reports that increased work intensity. And what I want to do now is show you the billing and coding article and where you can find that information. It's right here. This is the billing and coding article, and I know this. Here's the number, A57480, and this is the companion article for the local coverage determination I'm walking through. It is right here that we describe those 4 communication difficulties that would need to be present and documented in your medical record in order for you to bill the interactive complexity code with a psychiatric procedure. They're all right here. Caregiver emotions and behavior that interfere with the implementation of treatment plan. That's just one. Use of play equipment, physical devices, interpreter or translator to overcome significant language barriers. One thing I do want to talk about interpreter here, we're not just talking about those situations where a patient speaks another language. That's not what we're talking about here. We're talking about those situations where there is a communicative disorder of some sort and there is another type of language being used and there are those communication difficulties present. I just want to point that out, that it doesn't mean speaking a different language. It means speaking a language that is not being understood by the individual that's rendering this service. Okay, so just something to think about. All right, that is the communication disorders or communicative disorders for interactive complexity. WPS would expect, of course, that the medical record includes that documentation that justifies billing this code, and the record must include the listed items here on that slide. Must indicate why the patient doesn't have the ability to interact through normal communicative channels. It should include recommendations for future care, and of course include those adaptations that are used in that session and the rationale for employing those interactive techniques. So next in the local coverage determination, we provide coverage guidance for psychotherapy, and this includes a description. The policy also addresses maintenance. The expectation is that the therapy will be supported by evaluation and a plan with clearly identified goals. So that's what we would be looking at for in the documentation when psychotherapy is being billed. The policy addresses the involvement of family members in the treatment process. Let's talk about psychotherapy and E&M on the same day. We touched upon that a little bit earlier. To report both of these, your documentation, and the policy says this, needs to show that the evaluation and management service is a significant and separately identifiable service. There doesn't need to be a separate diagnosis, but there does need to be justification or recording in the record that shows the E&M service was indeed significant and separately identifiable. Next is psychotherapy for crisis. This service differs from psychotherapy because the patient is in high distress with complex or life-threatening circumstances, those that would require immediate attention. Psychiatrists or MDs often choose to report an evaluation and management service instead of billing for psychotherapy for crisis, but it doesn't mean that they can't bill for psychotherapy for crisis. The companion article states not to report those codes listed in bullet 4 with psychotherapy for crisis. So do not report psychotherapy for crisis when billing these services listed here in bullet 4. New in 2024 are two new codes, the G0017 and G0018, and these report psychotherapy for crisis when providing that service in a non-facility place of service. So this slide includes the place of service codes that our claims processing system is programmed to accept when billing G0017 and G0018. You can continue to report codes 90839 and 90840 or 90840 for psychotherapy when provided in the non-applicable places of service. And what we're talking about there is those facility places of service. Okay. So G0017 and G0018, new in 2024. I did previously provide some webinars on these particular codes, and you can find those out in the or on the WPS GHA YouTube channel. We actually have a mental health playlist, so that would narrow down for you where to find those the recordings for these particular codes. Since they were new in 2024, we wanted to provide some additional education on them. The LCD includes guidelines for psychotherapy services, that is documentation of them. This explains what WPS will look for in the record. The policy states that for those sessions greater than 90 minutes, we will pay only when documentation supports the medical need for an extended time spent face-to-face with the patient. So I just want to mention to you that documentation for psychotherapy, because we get asked this question, what are the documentation requirements for psychotherapy? And we actually have a separate section in our policy that talks specifically what it is that needs to be there in the medical record. And it is right there, folks. I'm not going to read through this. This is that entry-level introduction to mental health services, but I do want you to know it's there. So we specifically address documentation for psychotherapy service, and it's all right there written out in our local coverage determination. Okay. Of course, your claim would need to be submitted with a covered diagnosis, and I'll show you more about that in just a little bit. Providers who are rendering both psychotherapy and an E&M service need to choose a code that accurately describes this, and the policy actually includes those codes. I want to talk about family psychotherapy just for a bit to assist in the diagnosis and treatment planning. Sometimes the provider needs to contact family members or those other than the patient in order to get needed information. We do include family psychotherapy guidance in our local coverage determination. Family psychotherapy is covered, but only when the primary purpose is for the benefit of the patient. There are examples in the LCD, and what I'm talking about here is that Medicare can pay for this medically necessary service when the primary purpose is for the benefit of the patient. So it's not for the benefit of the family or to help them cope with the illness or diagnosis for the patient. It has to be for the primary purpose of the patient, and that of course would be reflected in the medical record documentation. Codes for family psychotherapy are shown here on this slide, and these shouldn't be used for taking a family history or for an E&M counseling service. Okay, so the policy explicitly says that about psychotherapy. And in addition to family psychotherapy, we cover guidelines for group psychotherapy in our LCD. Like for many other services in the policy, we have included the description. And the policy states that group psychotherapy must be led by a person who is acting within their state scope of practice. So many different types of providers. Of course, you would need to be eligible to bill Medicare for the service. But it must be led by a person acting within his state or scope of practice. And of course, there's incident 2 that would apply for this code. So sometimes the person rendering the service may not be enrolled in Medicare himself or herself, but based on his state scope of practice or her state scope of practice, they're certified or licensed to render that service. And if all incident 2 requirements are met, the provider who is supervising that service could bill for that service. But it does need to be led by a person who's acting within state scope of practice. Medicare does not necessarily know your state's guidelines. We do have some listings of certain certifications and such, so we'll know if it meets those Medicare guidelines, but it's pretty much up to the patient or the provider to make certain that any individual that is rendering an incident 2 service under himself or herself is certified or licensed to render that service within their state scope of practice. So Medicare does allow billing of interactive complexity with group therapy. That would need to be documented appropriately. So both the psychotherapy needs to be documented, and if you're billing that interactive complexity add-on code, you would need to also document the reason that you're billing that add-on complexity code. And remember, there are those 4 communication disorders that are listed in the policy, the billing and coding article, that need to exist. Those situations need to exist in order for you to bill that add-on code and receive that additional payment for that extra service or that intensified service. These limitations for psychotherapy are included in the policy. So these are just kind of a grouping of limitations for psychotherapy within the policy, and they are listed right here. Okay. Right? Must be led by one acting within state scope of practice. WPS says that this doesn't include teaching grooming skills, monitoring activities of daily living, so on and so forth. Those type of services are not covered as psychotherapy by WPS. Medicare doesn't cover oversight activities, and what we're talking about here is housing or financial management. And also, this is the section of the policy where we state specifically, I'm trying to get it to, stop highlighting. This is the billing and coding article, so I don't want to pull that over yet. But within the policy, it does state specifically that severe and profound mental retardation is never covered for psychotherapy services. You can see that right here on this slide, but if you look in the policy, you will find that statement. So again, WPS is in this LCD explaining what WPS considers as reasonable and necessary, as medically necessary for the coverage and treatment of a Medicare patient. So severe and profound mental retardation, a diagnosis like that on a claim for a psychotherapy service would be denied because it wouldn't meet WPS's medical necessity requirements. All right. The next section of the policy is psychoanalysis, and I'm scrolling over here on my other monitor because I wanted to pull up that policy and show it to you because it timed out on me. So if I could just get you to hold tight for just a second and pulling this up. CMS. Because I can't type and talk at the same time, folks. I've tried it. Oh, I do my best. Okay, here is that policy. I'm getting it here. All right, I've got it back. I'm going to pull this over while I talk for a little bit. So under psychoanalysis, which is near the end of the policy, I've told you I'm walking through, so I'm going in order. All these things that I'm talking about today, so right here. So the LCD provides a description for psychoanalysis, and it states that the provider who renders this service must be trained in an accredited program of psychoanalysis. If you take a look at these bulleted items here let me pull this back away. On the presentation itself or your handout itself, I've included what your documentation needs to include when you're billing this service to WPS. The indications for psychoanalysis, a description of the transference, and the psychoanalytic techniques used. So this is what WPS will expect is included in your medical record documentation when billing this service. We do also include in the coding and billing article the list of covered diagnoses for this service, and I do want to show that to you because I have received questions about this in the past. So this is the billing and coding article. I've been talking about things throughout my presentation today. That is the billing and coding article. Let me just get to right here. There is a group 1 of codes, and it says that the group 1 codes, these ICD-10 codes, must be coded to the highest level of specificity. And for these codes right here, these CPT codes, all of these ICD-10 codes are what WPS considers medically necessary reasons for rendering the service. So if you use this CPT code, any of these CPT codes, with these ICD-10 codes, then the diagnosis is covered, but remember, it needs to be medically necessary, which is what this policy describes, and otherwise covered. Okay, so it can't be a duplicate. You know, the person has to be eligible to receive Medicare payment, the provider. You know, it has to be rendered to an eligible beneficiary, and so on and so forth. So these are the ICD-10 codes that support medical necessity. Right there it is. So says WPS for this local coverage determination. We have group 1 codes. There's 739 codes. Here are the CPT codes. But the reason why I'm talking about this is because I'm going to scroll really quickly, so look away if that bothers you. I want to get to the second list of codes that we have in our policy. Okay. There's the group 1. I went too fast. I apologize. Let me go back to it. There's group 1. Let me just do it the easy way and do a find here. Okay. And there's a group 2 code, singular code, 1 code, and it's for hypnotherapy, which I'm talking about next. So I wanted to point that out to you. That actually, I'm going to talk about narcosynthesis, and then we're going to come back to this. So I'm going to leave it parked. I'm sorry about that, folks. I got a little bit ahead of myself. Okay. I want to talk about narcosynthesis because this is a service where specifically within our policy, we tell you what needs to be in documentation. There is a description in the LCD. You're going to need to Indicate in your medical record documentation why that patient had difficulty verbalizing his or her psychiatric problems without the aid of the drug. And then you're going to also include the specific agent, the dosage administered, whether the technique was effective or non-effective. So this is pulled right from the policy. This is what WPS will consider as medically necessary for narcosynthesis. And remember that list of codes that are found in the billing and coding article. For certain CPT codes, we can cover only this set of ICD-10 codes, so keep that in mind. Limitations for narcosynthesis. The LCD states that we will consider payment for this service only when it's provided by an MD or DO. So in this case, a non-physician practitioner can't bill Medicare, WPS Medicare, and be paid for these services, only an MD/DO. And here then is the last of the items covered in this policy, that being hypnotherapy. Like all of the other services within the policy, the LCD includes the description, describes the service. It states that this service may be used for diagnostic or therapeutic purposes. It also states that this claim must be submitted, or claims for this service have to be submitted with a covered diagnosis. And that's where I got ahead of myself earlier. I'm going to pull it back now. The group 2 codes in the billing and coding article say that for this CPT code, hypnotherapy, these are the covered diagnoses right up here. Okay. So something to think about. We have group 1 codes and group 2 codes that you will need to consider when determining whether or not you can be paid by WPS for a particular item or service. Okay. I mentioned to you that the LCD article does include those group 1 diagnosis codes, group 2 diagnosis codes, and that's how you will determine which ICD-10 codes are covered for what services. That is, if you're billing services for WPS. Couple of things to go over quickly here before I do open for what's going to be just a couple of questions and answers. CMS is asking us to provide this information. It applies only to Region 5 providers. So those of you listening in are Region 5 providers. So those of you listening in today from Indiana and Michigan. On November 15th, there will be a conference in Chicago. It's the Medicare Open Enrollment Event, actually is what it's being called. You can register now. If you click on that link or the link that Karen placed into the chat, if you look up that link, you will find details about this event. You can attend either in person or virtually, and you can register for it. So some great new information hot off the press that we needed to add to this program today. I do need to talk, and I'll do so quickly. CMS has issued a change request. Change request changes language within one of CMS's manuals, and those manuals provide instructions to providers and to the MACs. This change request, the link is included here, tells all MACs, not just WPS, that we must remove eligibility functions from the interactive voice response or IVR system. WPS has chosen January 1 of 2025 to do that. There are other eligibility resources, so you still have access to that. You just won't be able to use the IVR for that information anymore. If you're a registered user of the WPS SecureNet Access Portal, we call that product SNAP. That's the secure transactional portion or side of our website. You can use the SecureNet Access Portal. Eligibility resources or eligibility information is also available in direct data entry and HIPAA eligibility transaction systems. And finally, this is the last little announcement I need to make. You can access CMS Framework for Health Equity on the CMS website, and we have included the link right there for you. Health equity means the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health, regardless of race, ethnicity, disability, sexual orientation, and other things or other factors that affect that process or that access rather to care and health outcomes. So CMS wants us to share this information with you so so you know what they are doing to make certain that everyone has access to good health care at a reasonable price. Karen, we do have time for just a couple of questions before I have to finish up for today.
Okay, Mary, thank you for all that information. The first question that we have is, can G2211 be billed in addition to add-on code 90833 psychotherapy in addition to evaluation and management? Mary, if you're talking, you're on mute.
I apologize. I'm so sorry. You can bill the G2211 with a psychotherapy code. Should you bill it with a psychotherapy code? I can't tell you that because I don't have the information that's in your documentation. That is a great question. We're getting a lot of questions about the use of G2211, and that's that add-on code. What you'll need to do is to determine if you can bill that for a specific situation, because I don't know what else is billed on that day and so on and so forth. And remember, otherwise covered by Medicare. What I would recommend is that you check out the videos that of those recordings we've done on previous webinars for that particular code. One of my colleagues covered the use of that code very well, and I think that will be very, very helpful to you. One more question, Karen, and then we'll have to wrap up. And again, I want to assure all of you that your questions in the chat related to what I'm talking about today will be answered. I will just need to either reach out to you directly to answer or, make a list of questions and answers and get them to you. One more question, Karen. Go ahead, please.
Okay. Can an MD bill 90792 on one day and then they refer the patient to a clinical therapist, and on day 2, can the LCSW bill their own assessment and bill a 90791?
This is exactly that situation with the diagnostic psychiatric evaluation that I talked about earlier today. Medicare would question, why was there a medical need for that second provider to render that service? Absent the evaluation and management services that the MD did, why was it medically necessary for someone else to come along on another day and render the exact same service, that being the psychiatric diagnostic evaluation? So what's going to happen if that claim is submitted to Medicare? Whichever one comes in first is going to be the one that's first paid, as long as all of the other criteria for payment is on that claim, okay? The second service is going to deny, and that individual, or that provider rather, will need to request an appeal if he or she believes the service can be rendered a second time within a 6-month period for the same episode of illness. So offhand, I would just say, why was it medically necessary to do it again? Even though it's a different provider type, it's the same service that's being rendered, absent that evaluation and management part. And if that's the case, why was that one done the second day when, the diagnostic evaluation was already done by another provider? It could be payable, but the documentation would need to justify that. All right, great questions. I'm looking forward to seeing the other questions, and I'll be taking a look at those. But I am going to move on so that we can finish timely. For those of you that are looking for continuing education units, in a few minutes, those of you who are not joining by phone will receive an automated email from WebEx. It's going to thank you for attending. If you're seeking CEUs, don't delete it without reading it. This email does contain your certificate of achievement. It is going to look like what you see here on the screen. On the right-hand side, you'll see, first of all, we're kind of highlighting that survey that's so very important for you to provide feedback about this presentation today. See that one on the bottom is the certificate of achievement, and that is going to have your name, the name of this presentation, location, the date, the contact hours, which was 60 minutes, an hour today. And this is what you need to make a copy of and send to that accrediting body so that they can consider awarding you the CEUs. Now, if you are not one of those individuals, that it will get the automated email from WebEx because you did join by phone, you're going to need to send an email to the address shown on the bottom of this slide and on the next slide to our education mailbox. Give us your name, your telephone number, the name of this presentation, and the date, and someone will verify your attendance and will send you manually a certificate of achievement that you can present to that accrediting body for consideration of awarding CEUs. Here's the information about follow-up questions. I know we only got to a couple of today. I had a lot of information to present in 60 minutes, but if you send any follow-up questions within the next 7 days, send them by noon on 7 days from now to this email address. This is our education mailbox. In the subject line, put today's topic. You can just put mental health policy. That's good enough. You wouldn't need to place the official title of this exam. The important thing is that when this email or your question comes into the mailbox, they are going to know to send it to me, Mary Moko, to put on that list of questions and answers that I'm going to share back to all of you. If I don't answer you directly in an email. Now, one thing to remember though, and I have to caution you, please don't send any claim-specific questions to me. I don't, and neither do any of my provider outreach and education team members, have access to claim information or claims history. So we can't look at the system and see what happened to your claim, whereas customer service can. So those claim-specific questions do need to get sent to customer service. Here's the last thing before we say goodbye today. I do want to make certain you know how important your feedback is. Please take time to complete a survey. You can choose how you want to do that. Karen's placed a survey link in the chat. And it's so very important that you let us know, how did I do today? And those topics that you want to hear about in the future. Do we need to schedule a specific webinar and talk about 90791 and 90792? If you think that would be helpful, put it in those survey comments. We do look at each and every one of those surveys, and that is really what drives or what helps us strategize and plan education in the future. Now, if you don't take the survey, you're going to get yet another chance, because when you close out of this webinar in just a minute or so, you're going to get a redirect. It's going to be WebEx telling you, hey, we're taking you to another site, and it is going to be the CMS site. It's going to look like, the pop-up will look like what you see here on the right side of your screen. There's an image with a triangle on the top. It says external site, and there's a blue continue button on the bottom. That gives you one last chance, or not one last chance, but yet another chance to take that survey. CMS wants you to complete the survey. WPS wants you to do the same. We take those very, very seriously, and it is because of the survey feedback we've gotten that I'm here today talking about mental health. Okay. I do want to thank you for attending. I know everybody's very, very busy these days. Thank you for taking time to participate today. I hope that you will have an opportunity to join me for those other sessions that I'll be doing starting in December. I believe there are 4 more sessions that are mental health related. So I hope to see you in a future event. On behalf of myself and Karen, I thank you for your help today, and all of the provider outreach and education team, thanks so very much for your participation. We're looking forward to those survey comments, and we hope to have you join us for future events. You may now disconnect. Thanks, everyone. Have a great day.